Brilliant. Thank you so much.
I think Gillian Higgins was hoping to come, and I'm pretty sure Eleanor Robertson was also hoping to come.
They're here.
Let me see. Are they here?
I'm here, guys. Nice to see you all.
Hello, nice to see
Gillian
you.
just joined, yeah.
Brilliant. Thank you everybody for joining. I'll quickly introduce Adrian, and then we can get started. Everybody, this is Dr. Adrian Shields. He is a clinical lecturer in immunology at the University of Birmingham. And I met him when we were both F1s together at St. Thomas's Hospital many, many years ago now. Not that many years ago now. But thank you so much, Adrian, for talking to us today. And do let us know when is the best time for us to ask questions and have a discussion. Thank you.
So feel free to ask questions at any time, just interrupt, and it's probably better that this is a dialogue rather than me just talking at you. The first thing I'll say is, sort of with any of these, there's been a lot of webinars around SARS-CoV-2 and SARS-CoV-2 and COVID-19, and one of the questions I always ask people is, well, what makes you decide to talk about this? So I'll explain why I think I can at least comment on it. I've clinical immunology. I work at the Clinical Immunology Service in Birmingham. We're a specialist immunology laboratory, which is fully medically accredited to UCAS standards. Our main sort of array of tests support the GP network around Birmingham, but we've also got quite a strong R&D arm where we look at developing new tests for various things. We were concentrating a lot on myeloma and myeloma diagnostics before all this, and have done for about 20 years. But seeing as COVID-19 has come along, we're now sort of focusing our efforts at developing new diagnostic tests for that. Me personally, I did my PhD in sort of viral vector immunology, so looking at gene delivery in inflammatory disease. So I know a little bit about viruses, and sort of have been working on test development mainly for primary immune deficiencies to help various sort of individuals who've had whole genome sequencing done. They've got results which what they mean. I've been very interested in developing tests to help these people understand what those variants mean. So a little bit about test development over the past few years as well. So with that in mind, this is the bad guy. This is SARS-CoV-2. It's a novel virus, although it's very closely related to SARS-CoV-1, which caused the 2003 outbreak of coronavirus related disease, or SARS. And it's also related to a number of bat viruses that you can find in the Wuhan province of China, and we've proven that by whole genome sequencing. It's a relatively small virus. It's only got a genome of 30,000 base pairs. It's an RNA virus. That genome can make 29 proteins, and it's probably out of date now, but it has caused over 300,000 deaths worldwide. And this is what it looks like under the microscope, the electron microscope. You can see the little halo around the outside, coloured falsely in blue here, and that was the corona. And that's why it's called a coronavirus. I need not really tell you about how much morbidity and mortality it's caused in the UK. This is data I took off the internet from this weekend gone, just looking at excess mortality, which I think is probably the most reasonable way of sort of controlling for country to country differences in the way we report. And we've got a huge number of excess deaths, mainly attributable with COVID, but probably attributable to other people not coming to hospital in time for other things as well. My patients as a clinical immunologist have been exceptionally badly affected by coronavirus. As I'm collating the UK registry of patients with either primary immune deficiency or symptomatic secondary immune deficiency across the UK. Of the patients who have primary immune deficiency, the most common of which is CVID, we've got it's now a 33% case fatality rate in those patients. And in the secondary immune deficiency patients, we only see the very severe ones who've come out of bone marrow transplantation not doing so well and they get recurrent infections, but there's an over 40% case fatality rate in those patients. So we're very involved in people who can become extremely sick as a result of this virus. So I'm very strongly of the opinion that the way to understand the sort of epidemiology of this virus and to control it is using a test strategy. And what testing at a molecular level, so we're talking about PCR tests at this stage, what it allows you to do is rapidly isolate those individuals who are infectious and remove them from the population as quickly as possible to try and avoid them infecting anyone else, whether those individuals might be vulnerable or not. Then by sort of what we're trying to achieve at a governmental level in the imminent future is to have some sort of contract tracing in place to isolate those individuals who have been exposed to someone who is infectious but remain asymptomatic. And a number of countries have implemented strategies like this very effectively and have contained the virus, leaving the majority of the population unexposed, which is fantastic because they've really limited mortality as a result of this. So that is PCR testing. The problem with PCR testing in the UK at least has been twofold. Firstly, it was implemented relatively slowly. Certainly some of the NHS laboratories didn't have the capacity to scale up. At the University of Birmingham, we've got a workflow which we've developed to allow us to support the NHS as much as we can by doing staff testing. And that formed part of the paper that I'll present to you later on. The effectiveness of the containment strategy depends on really two things. Firstly, there's got to be a degree of public engagement. The public have to be on board with the idea that they're going to sort of be contacted by the NHS trace and contain team, and they've got to be willing to undergo a period of isolation. You also really need a highly sensitive test in order to pick out those individuals who may be asymptomatic and still potentially infectious. And the relationship between that test sensitivity and how sensitive you need your test to be really depends on how much disease is in the general population at the time. Because if you can imagine where loads and loads of people are infectious and your test does not detect all of them, you're always going to end up having a few individuals slip through the net and thereby infect many more people as you go along, which is problematic. And at the moment, we still have, I think, at least 10,000 new cases per week, which seems like a significant number of new cases when the test sensitivity appears to be around, in real life terms, about 70% for the PCR tests. This has led to a significant problem in the confidence, in sort of physician confidence, I should say, in diagnostic tests. This is data that we generated in collaboration with M3 Global Research, which is a London company that has access to hundreds of thousands of physicians around the world who are quite happy to fill in surveys. So we asked those physicians what they thought about what was their confidence in the diagnostic assays that they had available to them. And you can see quite marked global differences. It's been mapped out like a heat map with the lowest confidence in yellow and the highest confidence in blue. And you can see the United Kingdom is very much on the yellow end of the spectrum. This is data that was done, sort of the survey was delivered towards the end of March, and I'm sure things have evolved a bit since then. But even back then, if you looked at the relationship between the number of deaths that had occurred as a result of COVID in the general population and the confidence that physicians in those countries had, there was a negative relationship between those two parameters, suggesting that the more people who have died of COVID, the less confident physicians have in their diagnostic tools, probably because they've seen people die definitely with COVID, but not with any positive testing as they've gone along. Which brings us on to antibody testing, which is really what we specialise in immunology departments. Now, what an antibody is it's essentially the final product of a successful immune response. In order to produce antibody, pretty much all of the bits of the immune system have to be joined up properly in order to get the cell that produces antibodies, which is a B cell, to put out IgG, which is essentially what the vast majority of assays which are concerned with antibody testing are detecting. So in the context of COVID, an antibody is the end product of a normal immune response against the virus. By detecting antibody, what you're doing is saying whether that patient has or individual has been exposed to the virus and whether their immune system is intact enough to produce a response. And the vast majority of people in the general population, their immune systems are absolutely fine and they should be able to mount an immune response against the virus. So what we're saying here is when an antibody is present and we can find it on our tests, that antibody measures whether we're using it as a surrogate of exposure to the virus. That is different from some of the other things that people might infer from antibodies being present. A lot of people are saying if the antibody is present, then you are immune to further infection. It is highly likely that that is the case in some individuals, but not all individuals. And at the moment, with loads of different antibody tests available sort of in NHS labs, over the counter, on the internet, we simply can't say yet what level of antibody will confer long-term protection, or even if long-term protection is possible. So there are different ways of doing antibody tests. This is one way of doing antibody tests, and this is a picture of one of our, it's called an ELISA plate. What you see here is the end result of an antibody test. You've got sort of on the left-hand side, you've got something that says positive, something that says C, and something that says minors and minors. What those represent are, the positive is someone who's been in intensive care and has mounted a very strong antibody response. The C represents someone who has had convalescent disease, and the two minuses on the left-hand side are people who are or who've never been exposed to SARS-CoV-2 because the blood that we did that test with came from 2018. How yellow those dots are tell you how strongly the immune system has reacted to the protein that is present. And there are two things to note here. Firstly, on the two left-hand, the top left-hand, I don't know if I get my pointer working, but there are 6 sort of squares that have been outlined in that map, that plate. The one in the top left-hand corner and then the middle one at the top, both have a slightly different viral antigen stuck to the bottom of the plate than the one compared on the right. And you will see that if you look at the person who's got convalescent, so the C line at the top, it's slightly more yellow and indicating a positive result compared to the other two antigens on the left. The real sort of importance of this is that getting the right antigen from the virus, the right viral protein stuck to the bottom of whatever test you want to do is critically important. I'm going to explain a little bit more why. These are some tests that you can buy theoretically over the internet, although the government have said, ask people to stop selling them. These are called lateral flow tests, and they run off of, you can prick your finger and put a dot of blood at the bottom in the test window at the bottom, and then watch as a line develops. So of these, you've got 3 lines that you can see that might be positive or negative, corresponding to IgM, suggesting early infection, IgG, suggesting infection has happened quite some time ago, and then C is a control line to make sure the thing works. This was just a sample of 5 that I ran in our laboratory, and you can see at least one of them has gone spectacularly wrong with sort of the pink smear up the fourth test along, making it very difficult to interpret the G band there. And realistically, I did everything I could to try and make these things work. I didn't even use whole blood to put a dot on the bottom. I separated out the serum to make it as clear as possible, and still they are fairly unreliable. At present, the one thing I would say about antibody tests is that they are only an epidemiological tool. They're there purely to tell us how many people may have been exposed to the virus. So that means the result has value at a population level, but it doesn't have any value at an individual level. So that brings us on to how we've set up our test at the University of Birmingham. The story why we decided to develop our own test really came about after we brought in some more of these lateral flow point of care tests, because there was a pressure very early on for our laboratory to sort of start testing people. So we thought, well, these were available at the time. They were relatively cheap to buy in, and they came from China. And we ran into immediate problems with these. Allegedly, all these tests were made in the same batch by the same manufacturer, which is critically important when you think about the quality of the test, because it allows you to go back and see, well, if you get a dodgy result, you might be able to do some sort of quality management on that. And really, as you can see, the numbers 277, 27, and 8 could clearly be made from sort of a different time or using different equipment, because they've got a blue instead of a black markings on the side. And you can also see subtle differences if you look where the strips are actually within the test window, suggesting that probably these haven't all been made in the same batch, and yet these were commercially available at the time. So we thought we could do better than this, and we started thinking about how we wanted to go about that. The first question that we had was very much, well, what are we going to test antibodies against? So the protein, the virus has a number of different proteins that are the dominant antigens. The first is the spike protein on the outside. And that's the protein that allows the virus to gain entry into the respiratory epithelium and potentially other epithelial and endothelial surfaces. It binds to the ACE receptor. What that spike protein is actually a glycoprotein, not in much the same way as most viral proteins are glycoproteins. HIV-1, sort of the antigenic spike of HIV-1 is a glycoprotein, SARS-1 was a glycoprotein, SARS-2 is a glycoprotein. The thing about this particular glycoprotein is it's a homotrimer, which means that it's made up of 3 identical subunits which join together. And that's important, as I'll show you. SARS-CoV-2 is a enveloped virus, and beneath the lipid envelope, which it nicks from the cells that it comes out of, is something called the nuclear capsid, which is another protein, and that protein helps hold the virus together. It's a structural protein, and there is also an antibody response made to that in some people. Now, when you think about the antibody, what an antibody binds to is a shape in 3 dimensions. And in order to generate a test that is sensitive and has the best chance of picking up antibodies, you want to replicate that 3-dimensional shape as much as possible. And we call these things that they bind to conformational epitopes. And what that is a conformation of a protein in 3-dimensional space. And this is a really complicated figure of actually tells you how complicated the SARS-CoV-2 spike is. It's this is mapped out in 3 dimensions. Each one of the different residues has got its sugar content mapped to it, and this was done by our collaborators down in Southampton. So it is fairly complicated. Just to show you the shape of it, you need to get the shape right in order to detect the antibodies. With that in mind, there's been about 3 or 4 different assays that have been produced in order to try and detect antibodies. Many of them are based on the spike protein. Most of them are based on cutting out the tiny bit of the protein called the receptor binding domain, which is the bit that says RBD, and it's shown in RBD down and RBD up in these particular pictures. So you cut out a little bit of that, and then you stick it on the plate. So that measures only antibodies that bind to a small bit of the spike glycoprotein. Other tests just make something called the S1 domain, which is about half of one of the subunits of that homotrimer, and much more difficult to make is the full trimeric spike, which obviously offers you exactly this shape, but to make it is much more difficult, and you get lower yields unless you know exactly what you're doing. Then the other protein that you can use is called nucleocapsid. It's quite difficult to make in mammalian cells because it's a viral protein and it kills those mammalian cells for various reasons that I won't go into. But it's very easy to make in bacteria. You can make absolutely tons of it. But when you purify it from bacteria, it can also contain contaminants from those bacteria, which you can make antibodies against. And the quality of the preparation of bacterial antigen in these from the nucleocapsid preparations is really, really important to how specific your antibody test is. So lots of different ways of producing something against which you can make antibodies. And what we decided to do was, with our collaborators down in Southampton, who specialize in making glycoproteins, they very effectively made large quantities of the trimeric spike in its completely folded form for us to use for antibody detection. This is really important to get this bit right, because generally, across the population, the sort of people who you might want to send back to work with an immunity passport are the young people. And those are the people who might not really go to hospital. They're more likely to have very mild COVID-like symptoms. They might not even realise they've been infected at all, but might have mounted an immune response to it anyway. Now, those people make less antibody than the older, sicker people who end up in intensive care, or certainly hospitalised, as a result of this virus. So in order to generate a sensitive assay, you must have the right protein to detect antibodies against, and you've got to get that assay absolutely right, because you're dealing with a considerably less antibody to find in the serum of the individuals who you actually want to know who've had COVID, because you can count hospital admissions for COVID. What you can't do is count all the people who might have had it in the community. So getting a sensitive assay is super, super important. And that's essentially what I've just said. Antibody tests are pointless in ITU patients because we can tell all these patients have had COVID. They've probably all had an RNA swab done, and you can tell they've had COVID because they're all in ITU, ventilated for, on average, 10 days or so before they go back and have a long rehab on the wards. We don't need an antibody test to detect this. So we went through a number of iterations of our assay. This is the very first iteration of the assay where we started sort of really tuning it and trying different concentrations of the various detection antibodies that we've got. And we immediately found that we could get sort of a cumulative sensitivity much greater than that of the commercially available finger prick assays, even when they were run on serum rather than whole blood, from about day 5 onwards. And we were getting sensitivities up to sort of 60% just on our first attempt of making an assay. So we carried on, we refined, and it's taken sort of about 6 weeks to get to the point where we are now, where we're quite happy with the assay. And overall, we know that our assay is 100% sensitive for both hospitalised patients, and we've done 59 who've had PCR positive disease, and then another 31 who've had mild disease in the community who have happened to have had a PCR positive test, and we can detect them all. It's also specific, at almost 98% specific, and we've run 270 pre-2019 negative samples who would never have been exposed to the virus. So we're quite happy with the performance characteristics of the assay in terms of its sensitivity and specificity at this point in time. What we don't know is how the antibody tests that are being used by the government are currently performing. We know that the sensitivity of the Roche and the Abbott platforms are somewhere between 88 and 92% sensitive in hospitalized patients. But we kind of knew those patients already had COVID-19, so an antibody test doesn't really help. What we don't know is how these are going to perform in the community, which is really where you want a sort of assay set up to do a sero survey, which is what the government are trying to do. That's where you want your assay to perform. And so we went through iterations of the assay, and this was the first sort of set of commercially available test units that got delivered at the end of last week. And we're just in the process of evaluating those to make sure the commercialization process hasn't affected the sensitivity of the platform. In the meantime, we'd been to the University of Birmingham is on site with the Queen Elizabeth Hospital Birmingham, and it's part of the wider University Hospitals Birmingham group. And obviously they saw us developing this assay, the one that hasn't been commercialized, the one that we can still run by hand in the laboratory. And they wanted to know what the seroprevalence of their staff was. So this was the PREVENT study, of which the manuscript is now up online by medRxiv. So the hospital, or the trust, the University Hospital Birmingham Trust, is 4 hospitals across central and east Birmingham. We deliver care to about 2.2 million people. We've got the largest solid organ transplant program in Europe. We've got one of, in fact, the biggest critical care at the QE on a single site in Europe. And we've got about 20,000 staff. So we're one of the largest, if not the largest, employer in Birmingham, single employer. And during the peak of the first wave of COVID-19, on average, 3,000 members of staff were sick at any one time, which is a considerable dent in the workforce, given that quite a lot of them are frontline staff. So what we undertook was a cross-sectional study through all UHB sites towards the end of April. And what we advertised this through Trust social media. Obviously, there was a huge interest in getting yourself tested for COVID, given what's been in the media. And there were no exclusion criteria except for the fact that you had to be at work that day. So that excluded anyone who was self-isolating at the time because they were sick. And it excluded anyone who happened to have been rotated not to be on that day, given all the rearranging of rotas that we've done to make sure that the hospital is staffed. But we think, based on sort of the massive redeployment of people, that this is a fairly representative sample of frontline staff at the time. Participants self-reported for enrolment, and they were asked to donate both or volunteer a nasopharyngeal swab and also a venous blood sample for antibody testing. And we recruited 544 participants on a single day, which was a massive, massive effort to recruit that many to a sort of REC-approved clinical study on a single day. So they underwent a nasopharyngeal swab, which is jolly unpleasant. And then that went off for PCR. The PCR setup that we've got, you can read the precise details because it's just been published by Andrew Beggs's group. But it has, the PCR is set up to detect 2 targets, either a bit of the second open rate reading frame of the virus or the N protein. So it's got 2 targets, and it's got an internal synthetic control, which allows you to detect whether the assay has worked properly. So make sure there's no interfering factors if you get a negative result. Now, what has to be said about this entire work stream is the critical role in sort of the clinical immunology service as a UCAS accredited medical laboratory to actually provide some governance and oversight and quality management to the interface between a university genomics facility and NHS sampling. And that's been one of the major concerns about how you implement sort of academic laboratories into delivering testing strategies for NHS patients and staff, is that governance over sort of information governance, sample governance, etc., etc. So as a medically accredited laboratory cited within a university, we're in a quite unique position to be able to offer that. And it might be a model that works very, very nicely in the future for other academic institutions to facilitate helping the NHS when it needs help for future pandemics. So the PCR results, the bit of the test, the bit of the study that looked at whether people were infected or were carrying COVID RNA in them, detected 2.4% of individuals to be positive on that particular date. And there were two studies that you can compare that to. The first was done out of Barts, which detected a similar sort of rate of PCR positivity in the same week. It was somewhere between 2 and 3%. And that study is published in the Lancet. And then a similar study was run out of Newcastle by Chris Duncan's group towards the end or the middle to the end of March in healthcare workers, which found a rate of positivity of more like 10 to 15%, I think, overall. So as the pandemic we did this study after the peak of the pandemic, we were concordant with sort of other studies that showed similar rates of infectivity. So understandably, all these people were sent home to self-isolate. We'd also asked participants to give a saliva sample. And what we found with the saliva, because we tested that, just the individuals who were positive, we found saliva had a better positive predictive value for future symptomatic illness than a nasopharyngeal swab. And it also had lower CTs, which is essentially a marker of how positive a PCR is. So saliva, as well as being a more easily sampleable fluid, might well be predictive of it is predictive of future symptomatic disease. What we really need to understand is whether simple nasopharyngeal swabs, whether there's any discordance between infectivity based on those swabs and infectivity based on saliva instead, because it'll be much easier to collect saliva from people for PCR than nasopharyngeal swabs. We then had, of those 554 who enrolled, 516 gave blood for serological analysis. And this is the study population. The average age was about 40. And we had a mix of different demographics, more women than men, which is both reflective of the population who do the caring in the hospitals. And we think there's probably a slight bias towards females being enrolled in the study, but we need to compare that to sort of the trust data on male-female ratios within the trust. We've split the data up here, comparing seropositive and seronegative groups, and there were no significant differences in seropositivity based on ethnicity or on gender in the initial PREVENT study. And this is the data in terms of seroprevalence. So we looked first of all as to whether or not people who had symptomatic illness had a greater rate of seroprevalence than those who'd never been unwell. And there are two things to take away from this. Firstly, yes, symptomatic illness did predict higher seroprevalence when we did the study, but 17% of people who'd been asymptomatic since January had mounted a decent antibody response against the virus, were found to be positive, but had never been unwell. And the vast majority of those had been at work, working on the wards. Potentially, we don't know whether they were infectious or could have acted as vectors for the virus during that time. But in the absence of PCR testing being freely available to NHS staff during the early weeks of the pandemic, we simply don't know just how much of a vector healthcare workers could have been. This is data that's come off of, this is the actual read off of the ELISA. So each one of those dots represents a person. And on the left-hand axis, the y-axis is what's called the optical density. And you'll remember I showed you the plate earlier on. Essentially what the optical density is how yellow those dots are. So what we see here is two things. Firstly, the asymptomatic individuals, which are on the right-hand side, can mount high titer antibody responses. So they can make a lot of antibody without necessarily being ill at all, which is quite striking. Some people do that. But the majority of them don't mount significant or don't mount huge antibody responses. You'll see a slight clustering of results just above the cutoff of the assay where it says the dotted line saying threshold for positivity. And the distribution of these optical density results, i.e. how much antibody you produce, is different from the asymptomatics to the symptomatics, which is interesting from an immunological point of view. And what we really need to do going forward is understand whether if you've had a symptomatic illness, you are more protected in the future from reinfection than if you just have an asymptomatic illness. Or do the quality of these antibodies down here, the ones that have been made by asymptomatic individuals but only just meet the threshold for positivity, are they good enough? We simply don't know. And this is sort of one of the problems that we're finding with the interpretation of people wanting to know whether they're immune. All of these are going to be reported as positive, and you'll get similar sort of distributions of positivity on pretty much every antibody test that gets run. And we simply don't know if there's a big difference between these people who are running close to the cutoff and those people who make high titers of antibodies. We then tried mapping the data. So we knew that about a third of our staff had had some sort of symptomatic illness sometime since January. So we asked them to tell us if they could remember when they had that symptomatic illness. And then if they could remember, we mapped that to exactly when their projected seroconversion event would have occurred. So what we see here is back in February, if you look at the week beginning the 29th of February, where the yellow bars just come in, about 20% of illnesses that were occurring at that stage, symptomatic illnesses that may or may not have been COVID, were leading to, when we finished the study, positive antibodies. And similarly, you can see that rise about a week before maximum morbidity, maximum mortality occurred within the trust, which was in the week beginning the 4th of April, and then come back down again. The two bars on the right-hand side are obviously not present because those people, when we did the study, would have been mainly self-isolating at home. So what we think this means is that it's difficult to imply causation, but obviously the average length of stay of people who were sick was about seven or 8 days. And we think that obviously there may be some evidence, and we've got better evidence from PCR studies, which I haven't got the data to show you today, that actually people, the staff members, were being infected by their patients. And we can prove that two ways. Firstly, through temporal association on the PCR data, but also using genome sequencing. What was unique about this study was that we also noted, as best as possible, where people worked.
Sorry, I don't mean to interrupt. Sorry, it's Eleanor Robertson here. You just said, I'm working with Gillian Higgins and Dr. Douglas in Med Supply Drive Scotland. I hope you don't mind me asking a question.
No, please do.
You just made a massive statement around, sorry, I put my video on so it's not this black screen speaking to you, around providing evidence that healthcare workers are being infected by their patients. Yeah. Now, we're having massive issues in Scotland around enabling those in power to accept that we need reusable respirators for staff protection, that FFP3 are inferior for many reasons. One of the things that, from a providing evidence point of view for HSE, for example, for a RIDDER investigation, they're going to want to know that there is evidence to support that someone received their biological exposure at work. Mm. Is that something which can be demonstrated now with COVID?
We're getting there. I mean, the way to do it is to look at the temporality of staff PCRs who've had symptomatic illnesses, look at the sequences and compare them, because the outbreaks will have different. Essentially, we've saved all of the samples and all the samples.
Super.
Whole genome sequencing on the virus itself, or technically metagenome sequencing. Now that we don't have all of that data to string together yet, but we've certainly got outbreak data where outbreaks have occurred on wards initially, and then we've got sort of the temporal data to show the staff that worked on those wards.
Yes.
Then become positive.
Yes. So that, for me, is, I mean, there's been many, I know that you haven't finished your talk, and I didn't mean to cut in, but what you said for me there was groundbreakingly important. The other thing that is incredibly huge from your presentation, which is fantastic. I'm not meaning just to suck up to you. It's a really wonderful presentation. Thank you very much for putting a huge amount of effort into this and for sharing your work with us. So the healthcare workers who are at work, who have been asymptomatic, that 17% of them had COVID at one point or another. And again, what you're saying is that they are actually exposing themselves to patients and could have been, as you say, a vector, which again is another great push towards providing staff with reliable forms of respiratory protection, because as we know, with a valved respirator, what these staff members will be doing is blasting viral aerosol into the environment. They will be protected, but they will not be protecting those that they are working with. So what I'm trying to say is your presentation is incredibly important from an immunology point of view, but also from a public health and health of the worker, as well as health of the patient population point of view. So I'll stop talking now, but thank you incredibly for your points. Thank you.
I mean,
I was just going to say, sorry, Jasmine here. I agree. I was going to say something when Eleanor said it before myself, but actually this is quite significant from the occupational health point of view as well. And I'm sure you're aware that DAUK are fighting a battle right now to get it recognised that there is that risk of exposure at work, and that risk of exposure at work can amount to morbidity, but also in some circumstances mortality. So this is a fight beyond your immunology presentation, I think, and I just to signpost this, and also to ask if this is actually published, is this actually something that is quotable in sort of remits? But I'll let you discuss that in a second.
I mean, I think I'll come on to it in a second. I'll show you a little bit more. Yeah. I think this is probably the figure that's attracted the most attention from sort of the feedback that we've had from after posting the preprint. This is the figure that's attracted most attention. So we were lucky enough to sort of ask people just to note down where they worked as best as possible within the sort of people working across multiple wards and being redeployed. So what we did was then break down the seroprevalence data that we had from the antibody tests to sort of the area in which they were working the most within the hospital. And if we couldn't do that because they were housekeeping staff going to multiple wards, we would have said, well, you're a housekeeper then. So this breaks down as follows. The overall seroprevalence across the staff was 24%. That, in terms of what we know now and the early data coming off of the Abbott and Roche platforms, that's slightly higher than what's being delivered by the antibody tests that are now being run for NHS staff. And also we know that we ran our seroprevalence survey towards the end of April, and I'll show you some data in a minute to suggest that it's probably the levels that are currently being generated by the antibodies test for NHS staff is probably an underestimation of the true seroprevalence and true levels of exposure. So the overall seroprevalence at this point in time was 24%. The highest rate of seroprevalence was amongst the housekeepers. And there have been a number of explanations offered for that, which I'll go into later. We do have a relatively small group. It's only just under 30 housekeepers that we sampled that day. But the big group, I think, is the general internal medicine, or those people working on general internal medicine wards. And they had a seroprevalence of 30%. And I am relatively confident that that is a good representation, particularly when you look at acute medicine as well, of what the seroprevalence is there. People have asked, what does support services mean? Well, that's any therapists, so respiratory, physiotherapists, occupational therapists, and pharmacists, all lumped together so we can actually generate a group that sort of did similar things across different wards, worked in outpatient environments as well, to really sort of get a group that was sort of, we could meaningfully sort of analyse. The people who work in R&D have a lower seroprevalence, it's just under 20%. And what R&D means here is actually those people who work in the clinical trials unit, because we're a big clinical trial centre, and anyone associated with the various clinical trial units that are at the satellite hospitals. Facilities and estates are people who either work in catering, portering, electricians, carpenters, etc., etc. And then we get down to the real nitty-gritty. We've got a big group of intensive care doctors, nurses, who are running at a significantly lower seroprevalence than those working in general internal medicine and acute medicine. And then going even further down, general surgery, still obviously emergency general surgery still continued throughout the pandemic, but in sort of cold wards where people weren't, you couldn't get in there if you were COVID positive. One of the sort of the things that the Trust really wanted to know was, were any of these results explained by the fact that the people who live in, or the people who work in general internal medicine and have these higher seroprevalence surveys, are they higher seroprevalence? Are they living in areas which have greater levels of SARS-CoV-2 in the community? So are they more at risk of being infected at home? Now, clearly we couldn't do that sort of study because we didn't have PCR testing. We don't have data for the actual level of infective or the number of infections in different areas that's reliable. But what we can do, because we know that the Office of National Statistics have sort of mapped deprivation to COVID-19 related mortality, is to try and take, if you're dying of COVID, you obviously have got COVID in your particular neighbourhood, and if that is more deprived, we can work out indices of deprivation from the postcode to the people who participated, because they gave us our postcode to send them the results. So we mapped all of the postcodes to the various indices of deprivation that are available through government statistics. Now, probably there's a lot of data to look at here. There's no significant differences between those who have and haven't seroconverted in any of the parameters measured. The most important one is probably the indices of multiple deprivation, which is sort of a composite score of everything put together, and that's shown in subpanel A of this figure. But you can look at all sorts of the other ones, and there's no differences that's significant between the groups. So why do these differences occur? The short answer is we can't be 100% sure. The most obvious explanation is the quality of the PPE that's available to the staff in the various environments. And we know that the ITU guys have been geared up with full FFP3s, and all of ITU has been designated a high-risk area. Now, that's slightly different to what happens on the ward, where the available PPE is significantly likely to be less protective. At least that's my personal opinion. There are other factors at play that may or may not be contributory. On ITU, all the patients, certainly the COVID ones, are normally paralysed and ventilated. They're ventilated on a closed circuit. Those closed circuits have got HEPA filters in, so the exposure will be less. The nursing levels on ITU are more likely to be one-to-one, although our ITUs are absolutely chocker, and it wasn't actually one-to-one during the peak of the COVID epidemic. Your per patient exposure is going to be less because you're just seeing less people as a nurse, for example. Housekeepers and some of the other staff are also not directly employed by the trust. So there's issues about training and sort of whether they were appropriately trained to use the PPE that was available to them. And we think that sort of based on the asymptomatic people who've been hanging around wards but generating low-level antibody responses, there may be a chronicity of exposure effect where if you carry on being exposed to low levels of the virus that happen to be aerosolized in the atmosphere, it's almost like a chronic live immunization, not dissimilar to sort of a low dose of the live inactivated flu vaccine that kids get every year. Obviously that's designed to mount a good antibody response. If you get the dose right, you can mount a suboptimal antibody response. And with poor ventilation on the wards, bays of 6 people coughing all the time, potentially aerosolizing virus with little airflow through the wards, that may be contributory. I think the PPE is the most obvious, the most obvious explanation, but we can't completely exclude the possibility of other things as well. So this has led us to do the follow-up study. This is called COCO, which stands for COVID Convalescent Study. We've already recruited 1,000 high exposure healthcare workers who have had a symptomatic illness in the past, this essentially since February. And they've been enrolled, they've been bled for antibodies, and they've given a saliva sample, which we're storing down. And then we're going to follow them up now for 12 months. We've got ethical approval to go to 12 months now to look for whether, if they are antibody positive, whether they're going to get it again. And now we've got PCR testing up and running. We can actually prove infection or not if they do have another symptomatic illness. So that's going to be really important. This is the initial data from that study. This hasn't been published or put on any preprint servers yet, but on the left-hand side you can see all of the PREVENT data, and on the right-hand side it's all of the PREVENT data. So that's the first sero survey that we've done of the staff back in April, and then all of the data from our more recent COCO study, which has been enrolling slowly since PREVENT finished. And you can see that actually the level of positivity is now approaching 50% in our staff. And as a longitudinal study, we're going to find out whether these people are protected or not. There's been huge interest in this across the West Midlands. So now we're enrolling people from other professions. The ambulance staff are a really interesting group, having had to go into people's homes. We're getting the paediatricians and the paediatrics team from the Birmingham Women and Children's on board, and also sort of community healthcare teams as well, including dentists, to try and work out whether there's any differences between other healthcare professionals. We've got some other projects going on to try and make this more deliverable at a national level. Obviously, we're collecting saliva because it's a better, more easy fluid to sample, and it's easier to get kids to donate a saliva sample than it is for them to give blood. And this is just a proof of concept slide. Again, this is completely unpublished, but we've used our test to show that actually salivary antibodies are detectable even in people who are asymptomatic, and you can pick them up at reasonable titers on the ELISA that we've got, even if they've only had mild disease. So this was just a test run across the whole range of optical densities of the ELISA, showing that you can actually generate similar levels of positivity from the saliva as well. So this is pretty good news for sort of non-invasive sampling going forward, particularly we hope in kids. And in terms of sort of turning that into a test that can be bought over the counter, this is the very first run of trying to turn that test into something you could effectively drool on at home, and then it would run down a test strip, and then you can see the little dot here is actually a positive test result in someone who's had mild disease. So this is generating a pregnancy type test to be used at home on saliva. We're quite interested in using Guthrie cards as an alternative test means. So these are dried spot tests, dried blood spot tests, where you can extract the antibodies from these dried blood spot tests and then run them against on the ELISA. So you can post the cards to people at home who might be shielding, for example, get the cards back in the post, and then see whether whatever their sort of symptoms have been, whether that's attributable to COVID. And we've done 15 of those so far, and we've got really fantastic correlation with the serum results compared to the dried bloods. So this is another sampling fluid that we could potentially use for accessibility. And we are also running the Oxford vaccine trial, which we can talk about if people want to. This is the second phase of the Oxford vaccine trial, trying a adenovirus vector expressing the spike and comparing it to men ACWY as a control vaccine. So this has been a massive collaborative effort. The test could not be possible without the help of the University of Southampton and Max Crispin's group, who've really turned their lab into a protein production facility to generate sort of the best possible antigen that you could stick on and do tests against. So they've been critically important. Andrew Beggs has led the PCR front, and we've got sort of a fantastic clinical research or clinical trials unit up in Birmingham who really helped recruit all the staff to the studies. So that wouldn't have been possible without them. And I'm happy to take any questions at all about any of this work and sort of have a discussion about what it might mean. Great.
Wow, thank you so much, Adrian. That's absolutely fascinating, and also incredibly reassuring that there are so many incredible brains like yours that are working towards solutions. So honestly, it's sort of, I feel really much more positive. There are clever people working on all of these things. Probably the best way to ask questions is if there's a pause, just speak, or if there isn't an easy pause, then just comment in the chat and we can come to you next.
You can also raise your hand and I can see it.
Oh yeah, Jasmine will be able to see you. I can't see you on my phone. That's a great idea. Thank you, Jasmine.
Esther. Esther.
Hi. Yeah. Hi. Thanks, Adrian. Thank you for the great presentation and really interesting study. I just had a question about your really helpful thoughts already about the differential exposure from the occupational risks, because a lot of us here are very interested, because we're looking at the adequacy of PPE to frontline staff. I guess two questions from that. I just wondered if the emergency department, which was in between the anaesthetists and intensivists and the general surgeons, in terms of low seroconversion findings, is that an outlier, or in Birmingham hospitals, have they also been, the ED department, been designated as a high risk COVID area, and therefore everyone was having the better PPE from your understanding?
Designated as a high-risk area, but also anyone who came in with a cough was shuttled straight through A&E to the acute physicians without too much exposure to the EP.
Right, okay. No, that's really interesting. And I guess that's particularly context specific.
Repurposing of flow through hospital, I think, has had a big effect here. I think we're sort of, the ED was there to deal with emergencies, sort of almost non-COVID, because we're a big trauma centre. You had to preserve that service. People coming in with coughs were almost shunted straight into sort of the acute meds through an entirely separate flow through the hospital. And I think that has something to do with it. But it was designated a high-risk area. I don't know. Were all EDs across the country high-risk areas? I don't know the answer.
I think it was variable, so and also timings were different, so it was really that's quite important to get your context specific insight into that. So my other question was just related, was in all the different areas that staff self-reported as working in, did you have an idea of if they were all patient-facing roles, or I understood, like, for example, facilities, you had some porters who, I guess that would count as some patient-facing roles, or were there staff that were non-patient, like, for example, they worked in acute medicine wards, but were in an administrative role and didn't go into, say patient base, for example. Did you have a different kind of cut down on the staff exposures?
So we tried to do that. I must say it didn't work very well.
Imagine it's difficult.
Well, for two reasons. Firstly, because people are in split roles, so they might work. Certainly, a lot of the R&D people are working sort of a couple of days a week in R&D, running clinical trial stuff, and then other bits of their time patient-facing. We had some data to essentially, when they were enrolled, the people or the research nurses who were enrolling staff ranked people on a rank of 1, 2, and 3. To show whether they were high-risk patient-facing or low-risk non-patient-facing on that sort of scale. We had some criteria. There weren't very many differences, and part of the reason for that was that you've got housekeepers being ranked as non-patient-facing but going into patient wards. So the whole of what patient-facing is, i.e. interacting face-to-face with a patient, doesn't describe the exposure you might have within a clinical environment.
Yeah, and your point about the kind of chronic low titer exposure is particularly interesting. And I guess a lot of the government guidance might not directly cover the kind of cumulative risk one might be in the kind of low medium risk setting with some poor airflow and everything that you mentioned about. That's particularly interesting, really fascinating.
It's fascinating because we're not the only study to try and stratify like that. If you look at Duncan's Lancet paper, where the PCR testing on all of the symptomatic healthcare workers up in Newcastle hospitals back in March, his group tried to stratify things by whether people were patients facing on that 1, 2, 3 scale, and didn't find any differences either, actually. And I expect, sort of, for the reasons I've just said, that's the reason why it's just not a very good classification.
Yeah. Have you looked into or tried? I wondered if you asked these questions during data collected, whether staff felt they had sort of self-reported adequacy in terms of PPE supply to them and access to PPE, respective of their roles.
No, we didn't ask them that directly. What we're doing in an extension to the study is certainly there's been huge center of dentists, actually, because a lot of AGPs in dentistry. When we enroll the dentists, we are asking them sort of when they stopped work, when they restart work, and what PPE they might have available to them in practice, whether they're just using standard surgical masks and things like that. So that's really interesting. That's something we're doing later on. Yeah.
Really good work. And I think Jasmine's already asked this question. You must have submitted it. I was wondering where you've where it's been submitted to, and whether we could quote it in the paper form.
It got submitted first. I think I'm allowed to say this. It got submitted first to the Lancet, and they declined to send it for peer review. Then it got submitted to the BMJ, and they declined to send it for peer review. So we wrote to the editors of the BMJ and didn't get a response. So that took about 2 weeks to go through all of that. So now it's gone to Thorax as sort of the UK-based respiratory journal, and they have, well, last time I checked, they were trying to assign some reviewers to it. So what I will say is that the manuscript that's on medRxiv, we've actually just revised a few, not the data, but just a few things on there to describe it. I think it is a seroconversion study because I think nobody had antibodies to this, but one of the major points raised was actually what you've done is a seroprevalence study because you haven't followed people longitudinally. So if you do see a publication from our group, it might look slightly different to what's up at the moment.
Adrian, can I just, it's Jim Douglas, I'm interested in the occupational health perspective, and particularly the lack of efficacy of, or my feeling anyway, the lack of efficacy of the surgical mask. And essentially it boils down to what I think is a false dichotomy into aerosol generating procedures and not aerosol generating procedures. And the interesting thing about the data that you presented is it sort of maps the death data presented by Cook et al. In the Health Service Journal, where they looked at the deaths in 119 healthcare workers, and there'd been none in intensive care or anesthetics, and all the deaths were occurring in these so-called the low-risk areas. But then followed quite a debate about whether deaths are just the same as the general population, and people sort of going around in circles on statistics about what their figures actually represent. And you can go down a rabbit hole and that sort of thing. But the main thing that I took out of from that study was really just from a common sense point of view that if you're working in an intensive care unit and the patients, as you've correctly said, are intubated and asleep, most that you're doing is putting a suction catheter down somebody, then that's not a huge amount of aerosol generating procedure going on. The other interesting thing was if you look at the PPE guidelines, certainly the cleaning staff in hospitals, it says that masks are up to their own assessment. So basically they have to go around the wards. It depends which version of the PPE guidelines that you look at, but several of them, a mask is only just a kind of like an optional sort of thing because you're not necessarily in contact with the patients, and you just wear a pair of gloves and I mean, I've always thought that was just horrible that you're not providing the same personal protective equipment, even if it's a surgical mask, which I think is useless. Is there any space in any of your in your data where you just ask them to the simple question, which is whether they routinely use PPE3 or not, yes or no, and then trying to correlate it with whether the people that are wearing PPE3 work in A&E or whether they work in out with ATU in certain specified places, or dentists would be wearing PPE3, I would have thought. So is there any way that you can use that as your dividing line? The next question is, in your journal, I noticed that you've got a lower prevalence in surgeons as opposed to general physicians on intake wards, etc. Can you split that data up into specialities? So one would assume that ENT would be high, that ophthalmologists would be high, and maybe if you're an orthopedic surgeon, quite low. So I'm just kind of wondering, could that data be subdivided into speciality?
Possibly. So the first question about sort of dividing people up as to what PPE they've used, I don't think we can go back retrospectively and ask people what they were using previously, but we can certainly do that prospectively. And what we're trying to get ethical agreement to do now is sort of obviously all of this have been done under the same ethics, which has had to be amended twice along with the government missives about who's getting antibody and antigen testing. We're currently in the process of trying to amend the ethics to get it across multiple sites, which is phenomenally difficult, actually. I spent most of the day trying to sort that out. If we do things prospectively, we can then ask what PPE people have used and what is available to them, and ask opinions as to what they have. When we first conceived the very first bit of the study, which the data I've shown you, we were purely, actually, the sort of PREVENT study was mainly concerned with what the PCR positivity was at that point in time, because the government had snapped its fingers and said we want however many tests delivered by the weekend, and we decided to take antibody, blood for antibody at the same time. The metadata that we have for cocoa is much more extensive and includes where people have worked. I don't think it extends to PPE, because I think we wrote that before we realized that PPE is probably a big major issue, actually. We weren't expecting such huge differences amongst the staff as with those that we detected. But in the third arm of the trial, if we can get it going, we certainly can and will collect that data. With respect to your question about different specialities of surgeons, the data with regards to general surgery there is anyone who's working on the general surgery wards at that particular moment in time. What's happened to the vast majority of surgeons is that they have been redeployed to work in general medical environments. So there are a number of wards where essentially the lead consultants responsible for that ward have been orthopedic surgeons with sort of medical input. So instead of being classified as a surgeon for the purposes of this, they've been mainly working on ward 40, whatever it was, which is a COVID ward or a respiratory ward or whatever, a step down ward. So they've been put in the general medical bracket. We don't, of the people who are actually in that small group of general surgeons, they are people who are working in a bona fide clean ward, or indeed those who are working in the theatres, so theatre staff, whether that be ODPs or scrub nurses or whatever, who are there purely to provide the emergency service that we needed to do, because all elective stuff was cancelled for, I can't remember the dates, or even, I'm not even sure if it's still cancelled, but certainly it was off for a prolonged period of time during the first wave.
Fantastic. And the other question really is just the publication question. I think we're in our small group up here in Scotland, we're working towards some publications, and we would love to quote your data. And it's interesting that the Lancet and I'm horrified that the Lancet and the BMJ bounced it.
We don't know what's going on there. We're glad that Thorax has decided to take a look at it. I think I don't want to be conspiratorial about it at all. I think they're just, from what I can make out in terms of the amount of publications that have gone onto medRxiv, for example, has just been astronomical with people. And I think a lot of people are just chancing their arm, sending various stuff in to even the big journals. And I think there's probably as a editor of the journal, I expect a lot of these papers are being sort of viewed by relatively junior people, and picking signal to noise is exceptionally difficult, I expect, under those circumstances. I'd imagine the email traffic they get from people complaining that their paper's been rejected is huge. So I think the most important thing is that at least the preprint is out there, to allow people to read the data for themselves. And I'm glad that sort of it will get fair hearing at a reasonable journal like Thorax, to be honest. Fingers crossed.
Yeah, and a really excellent journal. So yeah, it would be great to get a copy of that when it's printed. But it's great to also be able to have access to it preprint as well. So we really appreciate that. I think Kate Hammer had a question. Sorry, am I putting you on the spot, Kate?
I just couldn't find my unmute button. I was kicked back and relaxing. Hi, Adrian. I'm a layperson. I'm very nosy. I heard you say a few moments ago the first wave. So I'm just curious what you're anticipating with regard to future waves.
A second wave, probably within. I would estimate the second wave is coming in the middle of June. I think we're going to slowly see things start creeping up. It really depends on what happens between now and mid-June, as whether that can be aborted in any way. But currently, I think if I read the data right, there's about 1,000 new cases in the community per week. And judging by some of the photos that have come out from sort of that are available in the press, there seems to be a complete disregard for any sort of social distancing or staying at home anymore. So I think with that many people and the insensitivity of PCR testing as we know it at the moment, sort of the best guess of the sensitivity in real world terms is about 70%. So you can miss 30% of potentially infected cases. I think that's going to be a recipe for disaster. And I would much, as someone who looks after people who got major problems with their immune system, even if I'm wrong, I would much rather prefer to be cautious, because sort of the people who I see in clinic, sort of I'm having to tell them sort of, well, there's a 40, well, the last person who I spoke to about an hour before coming on this, it's somewhere between a 40 and 80% chance of them dying if they catch this. And that's a horrible thing to have to tell someone. And I appreciate a lot of them are sort of missing loved ones, and a lot of people are missing loved ones, but we really have to, we've messed up the first response, part of the response to this pandemic within the UK. We really need to get the second bit right. Otherwise, you know, I'm not of the opinion we should be measuring sort of the cost of the economy in dead bodies, really.
From this point moving forward, if you had a blank sheet of paper, knowing what you know now about how the infection seems to travel both within hospital settings and then looking out to the community, on that blank sheet of paper, if you were to design your ideal provision, both in terms of physical distancing strategies and in terms of the circulation of human beings through a community, and then down at hospital level, right down to PPE. If resources were limitless, so it was simply down to your imagination, what would you design?
I don't think we've probably got long enough to discuss it all. I mean, I'm more of a, I'm not a public health expert. Being an immunologist, so I'd hate to, I'm well aware of people commenting well out of their area of expertise, to be honest. From the hospital perspective, the most important thing is the ability to be able to appropriately triage people as they come through the door. So what you need to do for that, you've got to accept that sort of some people coming through the door might well be asymptomatic with COVID. They might be coming for something else, particularly if they've come from care homes and things like that. So you need a diagnostic test, a molecular test, that can rapidly tell you whether that person has got COVID or not. And based on that, you can prioritize flow through your hospital and what sort of areas of the hospital you can send people to in order to isolate the individuals who are potentially infectious, or you can prove who are infectious. Based on that, you can provide the staff with high quality PPE if they are going into the environments where you've put everyone. You can protect the vulnerable people. We already know that sort of certainly within the lack of the lack of availability and the lack of sensitivity of molecular testing so far has led to outbreaks on wards where people have sort of tested negative, but despite having symptoms, haven't been isolated away. So you can achieve that, protect the vulnerable people, like the sort of people I look after, protect the staff. How you go about protecting seeding again in nursing homes and things like that. If you've still got a really accurate molecular test, you can actually test people before they go home and prevent the opportunity of that occurring. I'm not a public health doctor at all, and to me the major issue with the test and trace program that I can see at the moment is public confidence in the whole operation, and some people say that's been significantly damaged, and I really don't know how you get public confidence back in the current environment, actually, because having public confidence in what doctors, physicians, scientists, public health teams are doing is absolutely critical, and I really don't know how to do that. I don't know if anyone else is, the public health guys, I don't know if you can chip in as to how you retrieve the situation. I don't know.
Thank you.
Well, from the start, maybe I could just answer that point, Adrian, just by saying the main problem with the PPE guidelines is that they were constructed entirely by public health epidemiology type people from a very weak evidence base. And I'm interested, I respect completely for saying I'm not a public health person, therefore I would not go into their area of expertise. But I would say from a professional point of view, I think the people in the public health community have gone into other people's areas beyond their expertise and have been pronouncing on occupational health stuff, because if they had involved occupational health people right at the beginning, then people from the occupational health community, using the principles of things like COSH and precautionary principles, etc., would have said PPE3 for everybody. And I think part of the reason that we're in the mess that we are just now with deaths that we've had is because the public health community went beyond their level of expertise and didn't have the guts to ask the occupational health community, who are the experts on PPE.
Yeah, I think that's quite right. And to contrast how obviously, as we've set up our work stream, the University of Birmingham, with a virus that's potentially deadly being brought onto university premises, we're not a molecular virology lab, but we've been supporting the NHS. So the University of Birmingham has said everything that we do with regards to live virus has to be undertaken at Category 3 because of COSH and occupational health concerns, which is a perfectly reasonable position to take. And that sort of level of expertise to feed into how we operate and do stuff safely would have been invaluable from the start. I think you're quite right.
May I ask a question, please, Katie? Is there anyone else in the queue? Hi, Dr. Shields. My name's Gillian. I'm a surgical trainee up in Glasgow and work in the Med Supply Drive Scotland team. Sorry, I can't turn my camera on. My internet is playing up, but I'm giving you a wave. Thanks so much for sharing your work with us. I think, as everyone's mentioned already, I think this is just absolutely precious data to add to the existing literature regarding who is dying of COVID-19, and the fact that these people are not currently protected with the adequate levels of protection. And I'm really grateful for you sharing this work with us tonight as well. Thank you. I had a question about, you'd mentioned with that nice graph that with the orange and blue and the housekeepers.
Yeah, should I go back to it?
Conversion. Thank you. I was just wondering, am I right in saying that all of these people had been asymptomatic?
No. I don't think I've overlaid whether these different groups of people have been asymptomatic or not. The main reason that actually the groups are obviously representative of a whole of 516 individuals. And when you're talking about a 17% asymptomatic seroconversion rate, you're getting down to extremely small numbers in those individual groups.
Right, okay, thank you very much. And you'd mentioned that you could prove that people had caught the virus at work. You'd mentioned that would be through analysing the genomics from the patients and the staff who have the virus. I suppose also, if that would be possible, swabbing the environment for fomites in terms of housekeepers or people who wouldn't be necessarily in direct contact with the patients. Is that something that you're already working on, or something that you plan to do?
It's something that we're gathering data. We're sort of working on it, not our group actually, but sort of the wider University of Birmingham sort of team in infection microbiology, in sort of the University of Birmingham infection, what they call the Institute of Microbiology and Infection, who are doing a lot of the metagenomics, and the guys who do infection control across the trust as well. Mm-hmm. What we fed into that is the fact that we've collected sort of a significant number of nasopharyngeal swabs, some of which are positive, so we can feed that data into sequencing the virus. But the real answer to that question is looking for outbreaks on the wards, which we can do because we now got PCR testing up and running. Yeah. And then sort of knowing that X number of staff have been in contact with the patients who have been sort of working on those wards and seeing those patients, and then mapping whether they'll go down with COVID-19 within a reasonable time frame after exposure to those people, and then sequencing. The ultimate experiment would be to sequence those viruses. Yeah. And then we've got all the different sort of bits of the puzzle going. Yeah. You can pull all that together and actually demonstrate it.
I think that would be so precious in that there are politicians currently claiming that healthcare worker deaths are not necessarily related to the environment or their PPE. Initially, the coroners were advised not to investigate PPE in healthcare worker deaths. There was dying, but they'd all caught coronavirus. And I think that would just be the ultimate kind of evidence that these healthcare workers have caught this at work, and that is what led to their death.
I mean, and I think, we know that sort of exposure is at work is, I mean, it's disingenuous to say this isn't a major factor, because we know this from data from previous, you can take the SARS-1 pandemic, it wasn't a pandemic, it was an outbreak, I should say. There are a few papers that show, firstly, sort of the tests weren't very good back then, but you can do antibody tests, and you can look at the level of antibodies generated in patients and compare that to staff, and then compare that to the general population. And the ascending order of seroprevalence is general population, staff, patients. And then further studies have broken that down to look at sort of, well, what was your job? And if you look at the people who were nursing, so the nurses who were in direct contact with the patients who had during the first SARS-CoV epidemic outbreak, they had the highest seroprevalence. And then the doctors and the people who, on the whole, operate a little bit further away had a lower seroprevalence. So there's loads of supplementary, or there's loads of data out there to suggest occupational exposure for people who work in healthcare is significant. And
in addition to common sense.
Well, yeah. As I said, the clear experiment would be to, sort of do it on an outbreak basis and see who is exposed, because that would really nail down the answer for that question. If you prove same virus in patients, same virus X number of days later, in individuals who were caring for them, you've got sort of the temporal time period, you've got the same virus, and then you could go as far as proving they seroconvert as well.
Yeah, absolutely. I did just have one last question, in that you'd mentioned you're currently getting approval to make it a multi-center study.
Yeah.
Will that be a national study?
Well, the short answer is no. The current state of affairs with regards to antibody testing is that the government issued a request last Friday that antibody testing would be made available to all NHS staff and anyone who worked on NHS premises as soon as was humanly possible. Mm-hmm. That has caused enormous issues. It would also, the other thing they've asked people to do is, so the GPs, if they're doing routine blood tests, to add on an antibody test. Wow. Now, what that amounts to is little more than, in my opinion, a sort of unconsented additional tests that we don't really understand what it means yet, because as far as I'm concerned, these are still very much we don't understand what they mean. We don't understand whether they're immune. We don't understand the harm that delivering a result could do. So, just sort of telling someone, we know that people aren't necessarily respecting social distancing anymore. If you give them a positive antibody result and it proves that actually it's only just positive, and those people get it, it runs into enormous problems, and I don't think the potential for harm has been considered. So there is a national thing going on. We don't know how that's going to pan out, and also what we don't understand is how sensitive in the real world those sets of assays that the government have said are the approved assays actually are, because no one's done a head-to-head comparison with sort of all of them on the same set of samples. We are getting there with that. This is getting a bit technical, but as part of a medical laboratory, there are things called external quality assurance schemes, whereby essentially what happens is we're going to pool a load of positive people who we know are positive and send it out to everyone who happens to be running one of these tests, and then ask them to return their results back. So that's going to sort of inform us as to whether everyone's on the same page with all these different types of tests. And we might have some idea if everyone's results are comparable, but at the moment we don't. Our test is, we think that this all should be done through NHS, the ethical framework for research within the NHS, which is the HRA board, and we've submitted our amendments to the ethics, and for the time being it will be done in Birmingham, purely because sort of the logistics of coordinating governance of something of this nature, where we could potentially be testing sort of in the region of 25 to 30,000 people, is just enormous.
Sure. Thank you.
Adrian, can I just ask a quick, slightly silly question related to your name as Dr. Shields? Are you aware of the Shield Occupational Asthma Group? Now, I can never remember whether it's Birmingham or Sheffield, Sherwood Burge, etc. Do you know that group?
No, I don't.
All right. Okay. Well, one of the ways I kind of got into this whole topic was with occupational asthma many years ago, and looking to find IgE and IgG antibodies in a fish processing factory. And there's a very, well, the most active group in occupational asthma in England are the Shield group. So if you just Google Shield Occupational Asthma, I assume that they're still going. They're a bunch of immunologists, occupational physicians, etc., respiratory physicians with an interest. Obviously, I mean, you can only stretch the comparison to a certain degree in that it's obvious people can be allergic to proteins or to chemicals or whatever. And in any given workforce, whether they develop occupational asthma and express IgE proteins relative to what they're working with can depend upon a number of factors, like their atopic status, the agent. So generally speaking, sort of biological type agents will produce an IgE response. Say laboratory animal asthma, for instance, which is driven by the rat urine as an example, and whether people are smokers or non-smokers. But broadly speaking, if you just get any factory and you expose 100 people to whatever agent it is, 10% of the workforce will actually develop occupational asthma. And in the same way with, as you've described in COVID, you're getting kind of like symptomless expression of the footprint in the sand, if you like, immunologically. You get exactly the same thing in occupational asthma. So I'm just wondering, as a bit of a lateral thought, whether it might be worthwhile you contacting the Shield group, because obviously they've got decades of experience in occupational asthma and trying to interpret, obviously it's IgE responses, but trying to relate that to environmental data, etc.
Yeah, that's a fantastic.
And I wonder, I would suggest that the main, I'm not sure if he's still even working now, but the main guy was a guy called Sherwood Burge, B-U-E-R-G-E or something. He was or is a respiratory physician. And as I say, I can't remember whether it's Sheffield or Birmingham. It's one or the other, but they're a very active research group in a similar but slightly different group.
Yeah, no, it would be fantastic to get the opinions of sort of people who deal with sort of airway disease on a regular basis, and the relationship between environmental factors and airway disease. Fantastic idea.
So just Google your name, but put asthma on occupational asthma. See what happens.
Yeah. Hopefully not Dr. Google. Symptoms of asthma or COVID.
I've got a question, Adrian, about, I suppose this is the sort of optimist in me. Is there any optimism about the fact that locally are edging towards a 50% seroprevalence rate, in that actually subsequent peaks might have less of an effect on sick days and illness and death amongst staff members?
I don't know, actually, is the answer to that. The threshold for herd immunity being 60% is sort of theoretical, and I think what we'll find, if it's anything like any other respiratory virus, that the sort of people who've made stonking antibody responses might well be protected against this particular strain for life. Those people with sort of mild asymptomatic, sort of low levels of antibody might not have that same degree of protection. So the only way we'll be able to answer that is to carry on as a longitudinal study and really work out whether people are or are not immune going forward. Simply even doing sort of neutralization titers in vitro, so you can sort of get some virus and see if it infects cells, and put people's blood or a serum on and see if it blocks it. It's not going to be, it's going to give you a little bit more data. It's not going to be real life data to see whether these people do or don't get it. In 6 months' time, I might be in a better position to answer that. I really, I simply don't know the answer, because I don't think we understand enough about the antibody response in any great detail. And I think that's the same for all seroprevalent studies that have been done so far. I don't believe the ones that say only one population have got it. I'm not necessarily completely confident that we're right when we say probably 50% of the symptomatics have made a response. The truth is going to be somewhere between those two sort of realms of possibility. I think we're describing very high seroprevalence. We'll wait and see what happens. I'll come back and tell you in 6 months' time, 12 months' time.
You'll be careful what you promise, because we'll hold you to that if you have to come and talk to us again.
Can I
Are
ask
there any?
a question?
Oh yeah, go for it, Jasmine. Yeah.
Yeah, just the last one probably. Just carrying on from that question just asked, do you have a optimal time period for testing these antibodies in healthcare workers, or in fact population? Is there like a optimal time?
Yeah.
Like not so much like the, I guess the viral test itself, but I guess it leads on to the idea of how long is temporal immunity, and when should we try to really capture that?
So, to a certain extent, this virus is no different from any other respiratory virus, and the timing of your antibody response, you should be able to detect IgM in the blood by about 7 days after infection. Normally, what happens with most responses, if you give someone a vaccine, you measure the IgM first, then a few days later, you'll start picking up IgG. IgM being the first molecule that antibody gets produced. It's the big 5-pointed star antibody molecule, pentameric molecule. There's been a lot of fuss made about how soon you can pick these up by the tests that are available. The commercially available ones say you can only pick it up by about day 14, and a lot of the validation work that's been done on those tests has said day 14. To some extent, that's down to the insensitivity of the assays that are being used, but also the fact that a lot of people have been heat inactivating the serum for biosafety reasons. So they're worried that because all the initial tests were done essentially bleeding people on wards and things like that, they were worried there was still live virus, so they just heated it up to 60 degrees for 10 minutes or half an hour or something, and then they put it on. What that does is actually reduce the sensitivity of the test, which isn't great. And then you optimize your test based on detecting stuff that's hard to detect. With our assay, we know that we can pick things up within 7 days, which is what you're supposed to be able to detect. So the answer to your question is sort of depends on what test you're using, and also depends on what you've done to the blood sample before trying to detect the antibodies. But in truth, any good high quality assay should be able to pick things up from 7 days.
Perfect, thank you. Well, we won't keep you any longer. It's close to the 2-hour mark. Thank you so much for an excellent presentation. And yeah, I think we'll be in touch.
Well, yeah, and really delighted to be able to share this with you. I think it's just important to get the data out there, really, to as many people who are interested in it. And hopefully it will inform what we do next.
Yeah, just about this submitted data then, presumably we'll have to wait for it to really be accepted before. Can we say something, if we were to look at something like this, is it something that we could use in the interim? Yeah,
I mean, so to explain what a preprint is, yeah. In response to, it's happened a few years ago now, but in response to the problems in academia with essentially submission to a journal taking a reasonable amount of time, and then lots of people's jobs being dependent, particularly early career researchers and postdocs trying to move jobs and set up their own groups. These sort of preprint servers were set up in order for people to put their data on there, to allow other researchers and the scientific community to look at the data and then make a judgment as to whether they think it's good data or bad data or whatever, and give due credit to whoever did it. So that's the reason these things exist. The preprint servers for COVID, I mean, medRxive's the big one. The preprint servers are there's a huge amount of papers on there now. I think it's over 3,000 or something for COVID-19. So there's an awful lot there. Some of it's really good, some of it's really bad. And the caveat to all of it is none of it has been formally peer reviewed by someone with some expertise in it. That being said, the ones that are good or bad tend to end up on social media and either get sort of dissected by people on social media or sort of commented about an awful lot. So you can get some idea of at least the attention that a paper has got by the Altmetric score that comes, and you can find it attached to every paper. What I would say is it's now becoming common practice to cite preprints, with the caveat that whoever's doing the citing recognises that they need to come to some sort of conclusion about the generalizability and the acceptability and the quality of the data that they're looking at and citing, which is not an unreasonable thing. You should be doing that for any paper you read anyway. What's come to light when we put our preprints up, and obviously I sort of said seroconversion in the preprint, and people have said, oh, it's not really seroconversion, so we've altered a couple of other things to sort of make it more scientifically accurate, which is what a good peer review process should do anyway. So the manuscript that's in Thorax has got exactly the same data in, it's just, or the manuscript that's been submitted to Thorax has got the same data in, it's just, you know, the cosmetics have changed a little bit. I don't know if that answers your question. I've cited preprints before.
Yeah, it does. Yeah.
And it's in the public domain. Anyone can go onto medRxiv and read it and whatever.
Cool. Well, I better let you go unless there's any other pressing questions.
If there is anything else, just drop me an email. Yeah, and quite happy to answer it.
Thank you so much for your time. Well, I hope you get home soon enough and have a good rest after your shift.
Absolutely. My pleasure. And thank you for inviting me. Thanks for Katie as well.
Yes, thank you, Katie.
Thank you so much. No, it's really lovely. It's lovely to see you as well. But thank you so much for taking the time. It's been so interesting. Thank you.
We'll see you soon. And again, happy to talk again once we've got some more data.
Awesome.
Brilliant. Thank you so much.
Bye.
Stay safe.
Bye.
Bye.
Bye-bye.